Okay, hi everyone, and welcome to today's webinar on dense breasts. My name is Kelly Bunzlock, and I'm the Director of Prevention and Screening at CancerCare Manitoba, and I'm going to be your moderator for today. This is a group learning program. It's been certified by the College of Family Physicians of Canada and Manitoba for up to 1 MainPro Plus certified credit. But to receive your certificate of participation, you must complete an evaluation. The link to the evaluation will be sent to you via email after the webinar. So if there's more than one person participating in the webinar with you, please forward this link. The webinar, as you probably noticed, is being recorded and it will be posted on CancerCare Manitoba's website after today's session. The URL is cancercare.mb.ca/screening, and it's shown in the bottom right-hand corner of your screen there. So we'll be taking questions at the end of the webinar. Please type them in the chat box on your screen. If throughout this time you have any difficulty hearing or anything, you could just leave a note on the chat box there so that we can see. So now, without further delay, I would like to introduce today's speakers. Dr. Murray Wilson is a radiologist in Winnipeg and the medical lead for BreastCheck. He will be speaking about breast density, how breast density is a risk factor for breast cancer, how breast density is assessed, and BreastCheck screening and recall guidelines. And after Dr. Wilson's presentation, Mark Kristjanson will describe how BreastCheck has started communicating density information to women and will provide suggestions on how to talk to your patients about breast density and their personal risk for cancer. Dr. Kristjanson is the medical lead for primary care with the Community Oncology program at CancerCare Manitoba. So now I will turn it over to Dr. Wilson to get us started.
Well, thank you, Kelly, for that introduction and also for allowing me to participate in this timely CME activity that I think is going to add some clarity to the sometimes confusing and relatively new issue of breast density. But first of all, I need to declare that I have no relationships with any financial sponsors. This includes research grants, grant support, speakers honoraria, consulting fees. I have no other financial or political conflicts of interest. You could say that I am clean. In fact, so clean, not accepting anything. I might have to borrow money for lunch today, Kelly. Also, have to mention that I have no mitigating potential biases. So by the end of this webinar, the objectives are that the learners will be able to define breast density, identify and explain how breast density impacts breast cancer risk and also detection, identify the different ways that breast density is assessed, and explain the BreastCheck breast density assessment and recommendations. So first of all, what exactly is breast density? Breast density is a radiological term. It's not the usual scientific term of density. In radiology, density refers to the whiteness displayed on a mammogram. The term in part indicates that the relative quantity of glandular and fibrous connective tissue to fatty tissue at the subcellular radiologic physics level, I'm only going to spend 10 seconds on this, that it actually refers to the tissue with the highest number of free orbiting electrons, which are going to absorb the X-ray beam, not allowing them to penetrate and activate the digital detector on the other side of the breast. So this leads the algorithms to assign a white grayscale number to the particular pixel. So obviously, if there's increased amount of the tissue that absorbs it, it's going to be white, and the tissues will all appear very, very similar. In general, the higher the glandular connective tissue ratio to fat is, the whiter or denser the image is going to be. And conversely, the more fatty tissue compared to glandular and fibrous tissue, the more lucent or dark the image is going to be. Breast density generalizations. Dense breast tissue is more common in younger women. This is true. It's thought to most likely relate to hormonal changes and, to a much lesser extent, body mass index differences. The amount of dense tissue tends to decrease over time or with age. This also is considered to relate to hormonal involution of the fibrous and glandular tissue. These generalizations apply to the majority of women, but certainly not all. There are other factors which also contribute to the density, but these are by far the most important. Breast density and breast cancer risk. Breast density first cannot be measured with the clinical breast exam. The CBE will measure the actual breast firmness or the physical traits of it, but has nothing to do with the whiteness that's going to show up on the mammogram. And often it can be very surprising comparing the two tests. Breast density is not related to how the breasts appear, how they feel, or their size. Importantly, it's not an abnormal finding. It's just simply a trait. And also, it's not the only risk factor by far for breast cancer, but rather it's only one of many factors. And very importantly, this is not something that a woman is able to modify. Breast density and breast cancer risk. Breast density can affect a woman's breast cancer risk and detection in two ways. Firstly, women with dense breasts have an increased risk of breast cancer. This has been proven in studies. The relative risk is generally given at 2.5 times greater than for those at average risk. And just as a means of comparison, another relatively minor risk factor, that of having a high BMI score of greater than 30, this would impart approximately a 1.5 times increased risk. So these are all relatively small risks, but which can be additive. So having dense breasts does not mean that a woman will necessarily develop breast cancer. Despite these increased risks, there is no data to confirm association of dense breasts with increased breast cancer mortality. Extremely dense breast tissue does decrease the sensitivity of a mammogram, and the sensitivity being the ability of the mammogram to detect a cancer when a cancer is actually present. Dense breast tissue can mask a cancer on a mammogram and appear just like the normal tissue. This is because cancers and dense tissue are white on the mammogram. In Manitoba, approximately 6% of the BreastCheck clients have been classified as having extremely dense mammograms. Dense breast tissue and cancerous tissue can appear very similar on a mammographic image. This is an image which is considered to be a heterogeneously dense breast, not extremely. And you can see that the areas of white could very well mask a very small cancer or simply a benign finding within, simply because they're both white. Published data suggests that the masking effect of dense breasts on cancer detection is reduced with the use of digital mammography versus film screen mammography. This applies more to the mammograms that are moderately or heterogeneously dense. Because the image is digital, the radiologist is able to window and level the image in order to help differentiate tissue and better see subtle architectural changes, masses, or other findings that may signal that a cancer is present. In Manitoba, all of the mammography units are digital. They were bulk purchased and are identical in quality. BreastCheck Manitoba uses two categories at present for classifying breast density. The majority of clients are in the category of below 75% density, approximately 95%. And 5% to 6% of our population is classified as having more than 75% density on their mammogram. Now, this assessment is subjective and it's performed by many different radiologists and technologists. The technologist, when she completes her examination, will assign a classification score, and then when the radiologist interprets the mammogram, they will check that, and if they disagree, they may override it and change it into the other category. It should be noted that these categories are in fact arbitrary, and that they were initially launched many years ago with the intent to pool data for analysis from programs across Canada. Another system of classification of density has been put forward by the BI-RADS. Now, BI-RADS stands for the Breast Imaging, Reporting, and Data System and was established by the American College of Radiology. It's been a very useful system in both diagnostics and screening. It provides standardized breast imaging terminology, report organization, assessment structure, and classification system. This enables the radiologist to communicate results to referring physicians clearly, consistently, and include final assessment and recommendations. This was performed in order to try and standardize the quality of the imaging and reporting across varying practices and states. Now, BI-RADS has more recently added a separate category for breast density, where they've divided the breast spectrum into 4 categories, A through D, with category A being almost entirely fatty, which is the image on the far left. So you could imagine that a very small cancer, which would probably be white, would be very easily to detect, and it is. As you progress greater than 25 and up to 50% density is considered the scattered areas of fibroglandular density. It becomes slightly more difficult, but still very doable, so that the sensitivity falls minimally. Once you get into the heterogeneously dense and extremely dense, you can see that it will become a little bit more difficult in order to detect all of the cancers. This is just the categorical table, which lists A through D, with D being the most dense mammogram pattern. BreastCheck is currently considering changing to the BI-RADS system. When we explore it and decide whether or not this would allow greater research opportunity, this may be very important because there have been significant advancements in different imaging systems, namely breast tomosynthesis. These are just a few examples so that you can see visually what we mean when we're talking about different categories. This is a BI-RADS category A, and I would say this is sort of at the upper limits of the 0 to 25% fibroglandular tissue. Most breasts that are entirely fatty are quite lucent or dense with very little white material exhibited. But it's also easy to see that it would be very unlikely to miss a cancer even as small as 5 millimeters or less within this pattern of breast tissue. Category B is that of scattered areas of fibroglandular density. So you can see it's just an increase in quantity compared to category A. Also, for the most part, it's still going to be relatively easy for the radiologist to be able to detect a cancer within this. Next is category C. This is where the breast becomes more dense to the point where it is going to be starting to hinder the ability to detect cancers within. You can see the areas that are confluent whiteness, particularly in the central aspects of both images. It'd be very easy to imagine that a very small cancer could easily be obscured within. Finally, category D is the extremely dense tissue, and you can see that virtually the entire breast tissue area is quite dense, which could significantly reduce the ability to detect a cancer. This is a breast density pie chart, which was produced by the American College of Radiology and was published in 2018, just to show the relative distribution of these different breast density categories within the screening population. You can see in the dark blue part of the pie, this represents the almost entirely fatty breast, that it's approximately 10%. Their category B, which is the scattered areas of density, approximately 40%. The lighter blue portion also is 40%, represents the heterogeneously dense, and the extremely dense in the green section represent 10%. Next, we have a chart that the American College of Radiology also published, which just shows the relative stability of breast density category proportions within the general screening population over a period of time. They looked at the categories over a 13-year period, and as you can see at the bottom of the bar graphs, the dark or black area represents their category A, and that within this, the percent of the population would be approximately 5 or 7 up to 10%. The next darker gray category is category B, and this would be represented by approximately 35 to 40%. Category C are the heterogeneously dense, slightly less at 30 to 35%, and the very dense or extremely dense category Ds are represented by approximately 10% of the population. Now we have a figure which has been published from a Canadian group, the BC Cancer Agency, in 2018. They had started using the BI-RADS classification several years ago and have published their results. And as you can see, the fatty replaced category A makes up approximately 15% of their screen population, and that the sensitivity of detection of cancer was over 95%. Category B represents 44% of the population with a minimal drop in sensitivity to 93%. Starting in category C, which is the heterogeneously dense, 34% of the population is categorized as C, and sensitivity starts to decrease a little more rapidly, now being 86%. In their extremely dense category, 7% of the population was included, and approximately 75% mammographic sensitivity of detection. So I think what these are going to do in the future is that they will allow us to try new screening technologies and variances of frequencies and so on to try and fine tune and bring up the cancer detection rate so that the sensitivities will be higher. In BreastCheck Manitoba, we only have the two categories of classification. Our extremely dense breast, greater than 75%, represents 5 to 6% of our clients. Because we don't measure the other categories, we're unable to have those statistics. The prevalence of BreastCheck Manitoba women with extremely dense breasts is slightly lower than the literature estimates. Some possibilities for this include two factors. One is that it may relate to differences in the relative proportions of certain ethnic groups, and also our age range and inclusion policy. At BreastCheck, we invite by mail all women aged 50 to 74, but we'll also screen clients after the age of 74 if they simply book their own appointment themselves. This was instituted several years ago at the request of advocacy groups in order to avoid discrimination based solely on age. After age 80, We encourage the women to have a frank discussion of the risks and benefits of screening with their primary care physician to determine whether they should continue or not. As of June 2019, BreastCheck Manitoba reports breast density to BreastCheck patients and their healthcare providers for all normal as well as abnormal result letters. The reports include the breast density in one of the two categories, greater than or less than 75%. So just a quick review of the BreastCheck screening guidelines. BreastCheck currently recommends screening for women aged 50 to 74 who have no current problems related to their breasts, for example, no palpable lumps, nipple discharge, skin changes, etc., that they have no personal history of breast cancer. These clients are put into the diagnostic stream and undergo yearly post-cancer surveillance imaging. They also must not possess breast implants. They are recommended to be screened every 2 years. Screening mammograms are also recommended now for transgender men aged 50 to 74 with no chest surgery history, and also transgender women aged 50 to 74 who have been on hormone replacement therapy for a minimum of 5 years. Mammography is still considered in the literature the best test for finding breast cancer early in women with both dense breast tissue and without dense breast tissue. In the future at BreastCheck, we will likely review and overhaul our risk assessment methods in order to include more of the more recognized risk factors. Some of this work has already been started in the United Kingdom, where they are subclassifying based on risk in order to adjust the frequency of screening in order to detect the cancers in the populations that are greatest at risk. The BreastCheck recall guidelines refers to the determination of a 1 or a 2-year recall. Factors that affect the recall include a lifetime risk of developing breast cancer based on the family history. This relates to the questionnaire that the client fills out at the start of the exam. Women with Ashkenazi Jewish descent, they are at increased risk. Other diagnosed breast conditions based on previous breast biopsies, which included atypical duct hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ. These also impart an increased risk. And finally, the radiologist has the option to increase the frequency at least for one time based on the impression of this client's mammogram. It may be their first mammogram, such that there are no previous for comparisons. There may be asymmetries, which are considered very low risk. However, it's decided that it would be safest to have them seen in the following year. It's very important to remember that breast density is just one risk factor for breast cancer. Some of the more common ones include simply being female, increasing age. With every added decade, the frequency of breast cancer increases, personal history of breast abnormalities or cancer, genetic factors, and also family history. Other minor factors include smoking, body mass index, and also alcohol intake. So we've arrived at the bottom line, and this is, should there be additional testing based on breast density? At present, there is insufficient evidence to show that women with dense breasts who are otherwise at average risk should have more frequent mammograms or perhaps a different screening test such as MRI or ultrasound. Ultrasound is extremely operator dependent and very time consuming. MRI is very sensitive but has relatively low specificity such that it will generate a large number of false positive results, resulting in anxiety and extended workups. Mammography is still considered the most effective screening test for the screening age group in order to reduce breast cancer mortality. We do not recommend referring women for any additional testing based solely on their density. Okay, so this will conclude this portion of the program. We also have some printed and online resources. So I'm going to pass it back to Kelly to introduce our next speaker.
Okay, thanks, Dr. Wilson, for that. If anyone has any questions about his presentation, if you could please just type them in the chat box. We'll take all questions at the end. So up next, we've got Dr. Mark Kristjanson. He's the medical lead of primary care in the community oncology program at CancerCare Manitoba. And he's going to be talking to us a little bit today about how to speak to your patients about their personal risk of breast cancer and how that's affected by the breast cancer or the breast density score that they may be getting on their letters.
Thanks very much, Kelly. So, like Dr. Wilson, I have no particular financial stake in promoting a given product relevant to today's discussion, and therefore I don't have, to the best of my knowledge, any biases to mitigate, and therefore have no strategy in that regard. And I'd like to talk a little bit about what BreastCheck is doing around breast density, and talk about how to discuss breast density and other breast cancer risk factors with your patients. And maybe I'll take a minute just to give you some of my take-home points in case I take too long throughout the rest of the presentation. We don't miss these. For those of you who are frontline clinicians, you already instinctively know this, but the patient comes into you, see you, with a request that they get additional imaging or extra screening on the basis of breast density. One of your tasks is to, through careful listening and appropriate questioning, try to tease out what's the issue behind the question. And often it will be the very understandable assumption on the part of the patient that increased breast density puts them at increased risk of dying breast cancer. But as Dr. Wilson already pointed out, the literature actually does not support that. That's a bit counterintuitive because we know that increasing breast density makes interpretation of screening imaging more challenging, and there is a higher risk of being diagnosed with the breast cancer when you have very dense breast. But we don't have in the literature evidence to support the notion that the patient is at increased risk of dying from breast cancer just because she's got dense breasts. The other thing is that there are a lot of modifiable risk factors for breast cancer that you want to consider discussion with your patient, and we'll talk more about that. And finally, it's worth noting that the literature is constantly in evolution. So you can reassure your patient in a sense that the scientific and the clinical community are paying attention to this issue, and that there are new studies coming out all the time. And I'm going to touch very briefly on a couple of studies later on if there is time. Since June of this year, BreastCheck has been notifying patients, along with their result letters, of their breast density category, in the sense that they will tell the patient if their breast density is more than or less than 75%. They'll receive in the envelope the letter with their result, a breast density insert, which you see pictured there, and abnormal letters will also have an insert that explains follow-up testing. Just looking a little more closely at that breast density insert, and again, as Dr. Wilson has pointed out, there's a tutorial demonstration of the different breast density categories A through D. The most radiolucent being the A and the most dense being the D. And there's more of the insert there that includes some patient education resources, including pointers for the patient as to what they can for assessing their own breast. So again, you've heard this from Dr. Wilson, but breast density is a term used by radiologists to describe the imaging appearance of breast tissue. It's not a term in this context that has anything to do with the way the breast feels on palpation. There isn't a very good correlation between those two. So the patient comes in telling you that she's got dense breasts, make sure you clarify what the profession intends by the use of that term. Breast density is not an abnormal finding. It's just a spectrum of imaging impressions that depend on how much you've got in the way of connective and glandular tissue. More fat, the lower the density. More in the way of connective tissue and glandular tissue, the higher the density. But having very dense breasts affects a woman's breast cancer risk in two ways. First of all, it does increase the risk of breast cancer. For people in category C, which is the heterogeneous, the best estimate is that it's something like 1.2 relative risk. And as Dr. Wilson was pointing out, having the highest category, the D category, puts you at roughly double the risk. Dense breast tissue decreases the sensitivity of a mammogram by masking cancerous tissue. So breast density increases the risk and decreases the sensitivity of screening imaging. And here again are those pictorial representations. Again, breast density is one of several risk factors for breast cancer. Being female is the biggie. Globally, the incidence is 100 times that of men. Here in North America, the ratio is actually even more extreme. It's something like 200 to 1, but in Central Africa, where there's lots of men with liver injury from viral hepatitis, and therefore higher circulating estrogen levels, ratios not quite so dramatic. Once you're over 50, your risk increases significantly. About 10% of breast cancers are associated with an identifiable mutation, and 6% are specifically by BRCA and BRCA 1 and 2. Family history is significant, especially if you have a first-degree relative who had a breast cancer before the age of 50, or if you have more than one immediate family member with breast cancer. Also, a family history of ovarian cancer is important. Personal history, of course, is relevant. If you've had a previous diagnosis of breast cancer, though, you're not a candidate for population-based screening. You're going to be through surveillance. Atypical hyperplasia on a previous biopsy is a risk factor. Breast density is a major risk factor, but it's a non-modifiable risk factor. Those of you who have patients who had treatment for Hodgkin's lymphoma and who received mantle radiation, especially if they were an adolescent or young adult, that is a major risk factor. And their radiation oncologist can guide you and your patient with respect to what kind of surveillance they should undergo. If anybody wants to have a peek at the Dutch guidelines regarding surveillance for those patients, you can email me, and maybe I'll just take a second to give my email address. Kristjanson, that's MKRISTJANSON at cancercare.mb.ca. Hormonal contraception is listed as a non-modifiable breast cancer risk factor in the sense that by the time we're talking about population-based screening, that is a fact of the past. But might want to consider this issue when you are counseling your patients with respect to their contraceptive options, because there has been in the literature demonstrated association between the use of the oral contraceptive pill and women's risk for breast cancer. Interestingly, in a study that was put out about 10 years ago, that risk was most significantly in women who used the pill for a year or more under the age of 40, and it was not for the common ER and PR positive breast cancers. It was for the triple negative cancers, and they're more aggressive tumors and harder to treat. So that's worth considering, and I can point you to relevant literature in that regard if anyone's interested. Duration of reproductive years, menarche at an age less than 12 or menopause greater than age 55 by virtue of greater duration of exposure to estrogen increases breast cancer risk. HRT, especially if it's used for more than 5 years, is a modifiable risk factor. And the amount of alcohol you consume is a modifiable risk factor. And the relative risk getting a breast cancer increases by about 10% for each additional daily drink beyond 1 drink per day. Obesity, especially postmenopausal years, increases one's risk of breast cancer. And that, again, is a modifiable risk factor. Diet, somewhat counterintuitively, has been debated in the literature without findings specifically with respect to breast cancer. One would expect that diets high in vegetables, low in animal fats, like for other cancers, would be the better choice in terms of reducing risk. We don't know that for sure, although there is one study that does show an increase, or rather a benefit, I should say, in terms of decreased risk down the road if during adolescence you have an increased take of fruit. Exercise brings about a dose-dependent reduction in postmenopausal ER-positive breast cancers with a hazard ratio of about 9 for high versus low activity levels. So the Canadian Cancer Society has some helpful ways of depicting those modifiable risk factors for cancers generally. And for cancers generally, smoking, of course, is the biggie. The next big one in terms of modifiable risk factors is exercise. Diet factors in there significantly. We think that about 28% of breast cancers could be prevented by the lifestyle factors listed on that diagram. But again, at this time, there's insufficient evidence to show that women with dense breasts should have more frequent screening mammograms or a different screening test. One question that might come up in discussion with your patients is whether or not MRI should be added into their screening regimen. And again, the literature is in evolution on that question, and there is an interesting study that a bit more about if you want later on. BreastCheck has some resources that can help you in counseling your patients. Those are depicted here. Part of counseling your patient includes advising them on what to watch for in terms of changes in their own body. If there is puckering of the skin of the breast, if there's a change in the appearance or the texture of the nipple, if there's new discharge or bloody discharge, a change in the size or shape or color of the breast, or if a portion of the breast feels indurated, or if there's a new lump, you want your patient to report that. So what do you do if your patient asks you for more screening or a referral for other testing? Well, again, I think the take-home points are the following. First of all, sit down and lean in and ask your patient some questions that makes it easy for her to tell you why she's wanting the extra screening. Might find out something about the patient's family history that you didn't know before. You might just find that there's an opportunity to do some educating. Again, you can clarify for your patient whether or not her main concern is that increased breast density is increasing her risk of dying from breast cancer, and you can reassure her that the literature to date does not show association between breast density and mortality from breast cancer. And again, it's well worth your while and your patient's while to reflect on those modifiable risk factors for breast cancer. And currently, the literature does not support modifying the screening on the basis of breast density alone. So Dr. Wilson and I can entertain some questions.
So thank you, Dr. Kristjanson, for that. I see that we've got 4 questions listed up on the thing, and I think actually those questions were asked of everyone, so that's perfect. I'll maybe just start with the last question because it's the shortest answer, and then pass the guideline questions on to Dr. Wilson to answer. So in regards to who receives the letter from BreastCheck with their breast density classification, it is every woman who has a mammogram at BreastCheck will get her classification. It'll be listed either as more than 75% or less than 75%, but it's provided to everybody who has a BreastCheck mammogram.
Okay, it's Dr. Wilson here. I'm just going to start through some of the questions. First one is from Tiffany Walker. Could the trans female screening guidelines please be repeated? What the guidelines are, and of course there's not a lot of experience with this, but there are some studies out that show that the risk of breast cancer starts to rise once the transgender transformation has included hormone replacement of a minimum of 5 years. So that's been combined with the usual screening recommendation of 50 years, such that a trans female 50 years of age or older who has been on hormone replacement a minimum of 5 years does qualify to be screened. And this is of their own choice, and they can just phone in and make their own arrangements. They don't have to be referred. Next question is from Ethan Fatah regarding family. Is it maternal and I assume paternal genetic tendency, which is different? And in fact, these are quite different. In terms of the paternal genetic connection, this relates to the very high risk genes such as the BRCA genes. And these are very important because females with them have a minimum of 50% chance of developing breast cancer by age 50. So those will be screened in a different means, not through the BreastCheck program. They're considered high risk. So the father would have to have a very strong family history of first-degree relatives, namely sisters and mother, who had developed breast cancer at an early age. These people should be simply referred to the genetics clinic, and they will sort through their family history and advise regarding testing of other family members and also how to screen them. Question number 2. If there is history of breast cancer in the mother, at what age and what method should daughters and granddaughters be screened? Good question. This relates to the age of onset of the cancer within the mother. If it is a postmenopausal development of breast cancer in the mother, that imparts a very small increased risk and does not require any increased frequency or at an early age. So daughters, for example, of a mother in that circumstance would simply start screening at age 50 with mammography. If the mother had premenopausal or early breast cancer, then it's usually recommended that the client start having mammograms 10 years prior to the age of onset that the mother developed the breast cancer. Also, they would have to look seriously at the family history to see if this warrants a genetic consultation. Um, I think that's the end of the questions for now. If there's any more, please put them through. That's the one Kelly did, I think.
Okay, I don't see any other questions there, but certainly if you have any more questions after the webinar that you'd like to get in touch with us, our email address is screening@cancercare.mb.ca. That will come out to you in the evaluation that will be forthcoming. So anyone who's logged into this webinar will receive an evaluation, and once you've completed the evaluation, you'll get a certificate of participation by email as well. I'll just let Dr. Wilson answer that question before we close. Thank you, Catherine.
So the question is MRI screening preferable to mammogram in women less than 40 if they have high genetic risk? Now, by high genetic risk, you would have to, that would have to include a documented high-risk genes such as the BRCA1s, BRCA2s, and there is a host of other ones which have more recently been identified. If that's the case, then usually the screening will begin by about age 25, and there's no real set standard for it, but we, through the Breast Health Center and our surgeons, we tend to screen on a annual or biannual basis with MRI, alternating with mammograms in between. It's very important because there are a certain subset of cancers which MRI does not detect because these cancers are relatively low grade or they have not developed neovascularity. And these are namely certain DCIS cancers, and also some invasive lobular cancers will not show up at MRI. The calcifications of DCIS can only be picked up on a mammogram. And final comment or question is, can the presentation be shared with participants? This will be posted on our website.
Yeah, and in fact, the recording will be up on the website as well. So if anyone wants to watch this after the fact or skip ahead to certain sections, you'll be able to do that, I believe, within the next couple days. Sorry, I guess it's Friday, so the next week. Let's say poor Leslie's going to have to come in on the weekend. So I just wanted to take a second to thank Dr. Wilson and Dr. Kristjanson for providing practical clinical information on the topic of breast density. And thank you to all of you for logging in and participating today. We appreciate all the comments and questions. We do have a next education session scheduled for October 7th at 8 a.m. It's a cervix check competency training session. So in that session, we provide practical training on how to do Pap tests. And if you'd like to register, again, the website is cancercare.mb.ca/screening. And we do have a specific page up there that's dedicated to healthcare providers. So it's /HCP if you're interested in the information for healthcare providers. And as I said, the evaluation will be forthcoming to your inbox. So please feel free to let us know if you have any suggestions for future topics or anything that we perhaps didn't cover today. And thank you everyone for your time.
Hello, hello.